right. Thank you for inviting us. I think we're really happy about it. So I'm Fabio Gomes. I'm a consultant medical oncologist. So I work with lung cancer patients, and then on my non-clinical time, I'm director for clinical outcomes at the Christie. So I've always had an interest in data, real world data. As a clinician, you have questions, and I want to have those answers. So what is the best way of doing that? And for a few years, I shared our clinical. I was the chair for our clinical audit committee, and I think that interest grew working with the analytics team at the Christie. And then when that opportunity came to direct outcomes for the trust and have that focus on data, that was perfect for me. So I'm really pleased. You can tell I'm not from around here. So I'm Portuguese from Lisbon. I moved about 8 years ago to the UK, straight to the Christie, and been there since. And then Matt will probably also tell the story of his life, but Matt is our Deputy Chief Information Officer working with us, and is key in that unit and is key for the wider digital services as well. So I'm really pleased that he's here. But to get started, and I think this is quite a important topic for us. But I need to tell a little bit about the Christie. You would know the Christie, but just in case someone isn't fully aware about details, and I won't do a deep dive on it, but just to give you a bit of an overview for those joining us remotely as well. So we are the cancer center, the specialized cancer center in the region. We are the largest single-site cancer center. We do primarily anything that is systemic anti-cancer treatment, like chemotherapies, immunotherapies, all the drugs, radiotherapy, and also some of the specialized surgeries. We treat a large number of patients, and about 80% of these patients come from within the region, but 20% come from outside, and that's primarily for clinical trials. But we have quite a diverse population. And the Christie went through this huge process of thinking, where do we want to go? So for about a full year, all the strategies within the hospital were being reviewed, and they were trying to be aligned as well, because you can change one strategy, but if the other strategies don't change with it, you really can't deliver it. It's just another document on the shelf. So that process took a year. So that meant that every clinical service within the hospital reviewed where they wanted to be in 5 years' time. We reviewed our research and innovation strategy, our education strategy. We looked at our digital strategy, and we looked at our outcomes and data strategy. And we, after all of that, and we had that in place and approved a little bit over a year ago, or nearly a year ago, we came up with this mission when we thought about the outcomes and the data, and essentially my role and the role of the team. So really what we want is to improve the outcomes for our patients, but by having a more data-enhanced cancer center where we can tap into that data that we generate by the daily interactions with our patients to understand what is happening to them and use that for improvement. So really that is the mission. And obviously, I won't do a deep dive on the strategy itself, but I wanted just to give a bit of an overview because we have different missions within that strategy. And essentially what we want is to, and that's what we're working towards, is really modernize the way we're capturing data. And Matt will tell a little bit more about what we're doing with our redevelopment of our electronic health records, but we really just want to make sure that we are capturing the data that we want for our patients. But we need to be mindful that this is an NHS hospital. It's busy, the clinics are full. How can we have data, but which majority of it is captured by clinicians, but that works in clinical practice? Because yes, we could come up with a beautiful list of data that we would love, and no one would capture it because there's no time in clinic to do it. So how can we find better ways of capturing that data? We definitely want to use more data, but if we want to do that, we need to find ways to coordinate that and to govern that data. And hopefully by doing that, we can actually fast track that access to the data. And if we do all of that, is with the aim that we start monitoring outcomes. So one thing that I feel very passionate about is, yes, it's great to audit what has happened in the past 5 years, but I want to know what has happened yesterday. I want to know what is happening now. So obviously it's good to look back, but the problem sometimes with oncology is things change very quickly. So I can go into an audit of what happened over the past 5 years, but the standard of treatment today is different. So how can I learn today what is happening? So how can we monitor those outcomes and use that to make changes? And then mission 4, it's huge, perhaps because I'm a clinician, but I think it is important is that we enhance the clinicians with data. So we need that data to get to them. So I feel sometimes clinicians feel that, oh, here I am filling yet another form, but they don't see that coming back to them as a benefit. So we really need to empower clinicians by giving them more data. So if I want to quickly know how many patients I have on treatment X that have done well or been admitted with toxicity X, I need to be able to get that data fairly quickly. But to do that, we also need to educate the clinicians, because we can give amazing tools, but if they're not used to do it or don't trust them, then that doesn't happen. So that is a huge one. And then mission 5 is really about collaborating with trusted partners. So us being here is part of that, because we'll never have all the resources we want. We are an NHS trust, so we'll be looking at the patient and that day-to-day activity of providing that data for daily care. But we want to do more, so we need, and I think we thrive from collaborating with others. So really, this is the, in a succinct way, the 5 missions. Now, one thing that we've agreed that we needed to was a vehicle to deliver that strategy, and that's where the clinical outcomes data unit comes. So this is something we've launched in August, and some of you might have seen the new Patterson Research Building. So we've moved the team there, which is great. So it's the first time that the team, a lot of them worked for many years, even from home primarily. So now we brought all the team together. And I wanted to highlight that this is the first time that the Christie recognized such an importance to this, to the point that if you were to find the time to read the Christie strategy for the next 5 years, the corporate strategy, there's a huge focus on data and outcomes. So this is the first time that the Cancer Center that has done such a recognition that, yes, we need to focus on data. We have an obligation to use the data we capture for our patients. So that is massive, and that has meant all the changes we've done. So this unit, what is this unit, you might be asking? This is the first time, at least to our knowledge, that a NHS Trust has done this. So we pulled all these teams together. So what we've done is we brought our data analysts that we already had in-house, our statisticians, our data scientists. We brought elements from research and innovation because we want to enable the use of data for research purposes as well. We brought our clinical audit and quality improvement team, who essentially supports and monitors the whole process for the use of data for non-research purposes into that space. We want to ensure the data is governed and protected, so we brought information governance. And then obviously, I don't want to be the only clinician there annoying the team, so we want to bring clinicians in there, having more ideas coming, and we've launched Outcomes Fellowship. So our first fellow arrived in December, and we plan to grow that as well and bring more champions. We want those questions. And because, yes, the strategy is there more to enable clinical teams and clinical services that have a question and get them the data and support them, but we also want to lead or co-lead some of those more trust-wide issues. So really having clinicians into that space is quite key. So essentially, we brought teams that existed there, but never perhaps worked together that much. So this has made a huge difference, not only in efficiency for us to get data out and get it approved, but in terms of where we can go next. And we've grown the team. So we currently have 35 core staff members. So it's a decent size for an NHS hospital. And we plan to keep growing. And Matt was away on that day, so you're not on that picture. But yeah, so it's really nice that we brought all those teams together. And you might say, well, but almost what are the services that unit provides? So essentially what we're building, and as you can see, we've launched it in August, so there's still a lot of work that we are doing, but we are building it so that it is the central access to our data warehouse when it comes to clinical data for our patients. It's the place that you would go to provide intelligence about what is happening to those patients, to provide data quality assurance, because we need to ensure we can do that. So what we want is someone asks for data, and we want to be able to say, here's the data, but this is our confidence, this is our level of data quality, because yes, we're giving you, and obviously there are different dimensions for data quality, but we want to be able to report that. And that is relevant for our clinicians, is relevant for our boards when we want to provide assurance of what is happening, and is relevant for the public if we want to put things on our websites, etc. There's a lot of pressure to get more and more of that information out there. So yes, that's a big one. And then is empowering clinicians to use this data, is supporting, because sometimes clinical teams may not have the know-how or may not have the time to do the stats, especially when we get more data science and things that be more complex. Clinicians need a lot more support. So we need that, and that team is there. And then is about facilitating that use of data for clinical audits, but also for research. And one thing that we've been talking for a little while and we want to do, and we haven't done, I would say, is use more data for the purpose of education, because we can use that to train people. because we have all that data there. So that's a big one that we also want to focus. So this won't be news to any of you, but essentially what happens day to day, we'll have clinical data coming into our systems. We'll have treatment data. So the specifics, which treatment was it, which dose, when was it given, was there any issue with it? We'll have genomic data coming in, pathology data, imaging data, and we also have a huge piece of work that has been growing over a few years now, which is our patient-generated data. So not only are clinicians putting data into the system, we now have patients as well putting data, reporting on their symptoms, their functional levels, their quality of life. So that is massive, and that is growing and expanding. All of that feeds into our electronic health record, which actually we use CWP, Clinical Web Portal, which is not an off-the-shelf product. So I wasn't involved at all, but the smart people managed to build it and maintain it within the hospital. So we have something in-house that really gives us a lot of flexibility and allows us to change and redesign. And again, Matt is going to take you through some of the key changes that we're doing within it. But obviously data comes from outside that main system as well. So we have more data sources that fit into our data warehouse, which the team then has access to. And it is a busy unit. So to give you an idea, there are 3 new requests for data every working day. So that's why the pressure is quite high to get more and more. And you might say, well, some data requests might be simple, and yes, they might be, but there might be others that will take quite some time to make sure that that data is correct and work with the teams to clarify exactly what are the specifics of the data that is needed. And then on the second graph there, you can see the number of non-research projects that are registered and approved happening every year and how that has been growing. And we see the same with research. So this is a huge demand on data. And as you can imagine, this day-to-day process of dealing with data requests consumes the majority of the resources. Nonetheless, there are a lot of things we want to do, and we're having some strategies to try to minimize at least the more simple data requests to give more autonomy to the users to get access to that data, so they don't need to get through the unit and could be a little bit more autonomous. But apart from that day-to-day activity, which is our core business, obviously there are key deliverables that we want, and some of them we're already working, some are in the pipeline. And I just wanted to give you a feel and a taste for that. So essentially, one of the key things we're working is towards establishing what will be our minimum cancer data or cancer data set. Because yes, as I was saying before, we could have loads of data. Is it feasible? Is it going to be captured? But we can all agree that it's a cancer center. We need to know the diagnosis of the patient. We need to know the staging, etc. So we are agreeing that, and that is part of this redevelopment of our electronic health record. We are working, and we have a really close collaboration with Gareth Price and the team. So we have data analyst experts in data quality working with us because we really need to understand that, and we need to be able to monitor that. We are expanding that patient-reported data field. And one thing that we realize is over the years, because there wasn't this one-stop shop approach in the hospital, many different teams across the center ended up developing their own databases. So we have teams that have quite complex databases that don't sit in our data warehouse, and that we want to be able to make sure that there's a future to that database and this doesn't just disappear when someone leaves the trust, and that we can access it and it can go into our pool, we can recycle and reuse it. So we are discussing strategies to try to bring all of that together. We want to improve that access, and we're working towards developing, and we already have more and more dashboards that users can access and visualize data. And we want to go beyond that merely enabler role, although that is the core. Now that we have the fellow and we're expanding the team, is to have more projects initiated by us and co-led by other clinical services. So clinicians is quite key. But as I mentioned before, yes, you can bring clinical champions, you can bring junior doctors as we did already, but then you need to improve that digital and data literacy, because yes, if they don't understand or don't trust that system, then they won't use it. So that is quite key as well. And then finally, around the collaborations. And one thing that, and Matt will do a deep dive on this is, yes, we can talk about AI and we can have questions and we can develop it, but how do we implement it in the NHS? How do we implement it to the patient? And how do you give trust to clinicians to use it? And we've had challenges with that already. So I just wanted to wrap up before bringing in Matt, just to take you, just a little bit about, the CODO team in action. And as I was joking with Matt, this is the mandatory outfit, so people have to come to office like that. But just some things that we have been doing. So in the space of health inequality, and that's a big one, we've been looking at ethnicity data, and we've been looking for a little bit longer at age and the effect of age. And we've seen that, older patients, and saying older, 70 plus, is the fastest growing group of patients coming through our services. They are already more than a third of the patients that get referred to us. They represent more than half of our outpatient visits. And then we mapped out outcomes. You could see that those patients had worse outcomes. And a lot of that work has led that last week, the NHS funded a new service at the Christie to support older cancer patients. And data was key to make sure that we understood what was happening to them. The other aspect is data-enhanced clinicians. So clinicians need to be able to see where are their patients coming from. Because, for example, I cover at the area of Wigan, Bolton, and Salford, primarily for referrals for lung cancer. There are some treatments that could be quite challenging because there's a long traveling for those patients. So how can we find better strategies to deliver treatments closer to home? Where are these patients getting admitted, and how often are they getting admitted? So bringing this data to patients, to clinicians is key. And then clinicians want to know what is happening to those patients in terms of outcomes. So we've built this real-world data toolbox where clinicians can go and play with the available data. And there's a lot of data there where they could see and filter and could see survival curves for cohorts of patients. They could see, so this is an example, I don't think we can read it very well, but this is an example. We had an cancer patient, so we can see what was their first-line treatment, what happened after the first-line treatment, did they get a second line, which one was it? So we can understand the pathways. We can understand what is happening, and we can visualize it in better ways. So all of this has become available to our clinicians to use. And then, data quality I was mentioning, what is it that, is it just missing data that is inaccurate? What is it? How can we quantify that? So we started looking at, missingness, for example, and being able to identify where our weaknesses are and where we need to find strategies to improve that. And then finally, before handing over to Matt, is AI. Yes, we can build it. But then how do you implement it? And this was an example of the team working with clinical teams trying to predict when patients would have acute kidney injury sooner. And then we had resistance from, it was almost a divide where half clinicians said, oh, this is exciting. And then the other half was like, oh, what is this? And then how do we implement this? Do we need to implement this as a research project, go through ethics? Is this a quality improvement project? What is the route to implement this in the NHS? So we've been working, trying to think about framework, about how to implement this. But we still have a long way to go. But definitely it's something that we want to do more of, but we want to know how to do it best and how to get it to the ground so that it actually benefits patients and it goes beyond an exercise. So with that, I'll hand over to Matt to do a bit of a deep dive on some of the redevelopment we're doing with our electronic health record and how to, on our work and how to implement AI tools. Thanks, Matt.
Great, thank you very much. I'm Matt Hewitt, I'm Deputy CIO at the Christie. I've worked there over 20 years now, which is quite scary. So I just want to talk through a little bit about our EHR and something called Open EHR, which some of you might have heard about. And then just go into a little bit of detail about our AI journey, which is something that we're probably rebooting a little bit now. And I'll explain a little bit more as to why. So I just want to start with this one. So data standards. So hopefully you can all see and appreciate that this is quite a dirty kitchen. So I'm just going to do some comparisons here just for a bit of fun. So if you're an analyst, sometimes you get hold of a, spreadsheet or somebody's database, you're asked to provide an outcome. And you open the door to that spreadsheet or database, and it's like opening the door to this kitchen sometimes, in that you might see that the data's actually in a bit of a mess. Not everybody can see that. So there's quite a lot of skills, experience, and standards that can help get this into a clean situation so you can get the right outputs. So just to run with this just for a little while. So it might be that this particular kitchen, there's certain circumstances that have led to this happening. And it might be that it's a shared kitchen. It might be that nobody's got that responsibility of actually tidying it up. That could have happened over years, not necessarily 5 minutes like when my kids come home from school and just make a mess, but it's not quite to that extent. But you can see how these things can probably build up in the data environment. So when you've got a task to clean something like that, particularly from a data point of view, and again, I'll run with the analogy. If you said, can you clean the worktops? That usually takes 5 minutes. But if you're going into a situation like that, you can't clean the worktops because you can't see them. So it doesn't take 5 minutes. You've actually got to do a load of other things, probably hire a skip in this situation first, which you wouldn't have expected. So it means that when you build up these situations, it's a bit of a problem. And that's where some of the data standards can come in. So that slightly says open EHR underneath that. And that's a standard for storage, for storing and managing and sharing healthcare data. And it's a real fine grain of clinical content. And the way I see that is it's a little bit like getting a new kitchen or having a really tidy and clean kitchen right from the start. So with that picture, again, just to run with this comparison, if I said to you with that kitchen, something like a magazine and a cup on the side, can you go clean it up? Now, inherently with that environment, you can tell the magazine and the cup on the side and you can go clean it. But if I said that in that situation, where do you start? You can't do it. So this is some of the problems that we've got with data, and this is where the standards come in. So what can we do right at the start to just keep people on the right track with their data, keep it stored and collected, hopefully in the right way? But from a kitchen point of view as well, it doesn't matter what colour or configuration it is. It's all about the point of that. So yes, you can get a different designed kitchen. You could get a different designed EPR, and that's fine. It all reaches hopefully then the same goal of managing that data. So this is just a little bit of a dive in. Now, you might have seen things like this where there is a comparison of monolithic electronic patient records versus open modular ones. And it's not necessarily to say that one is better than the other in a certain situation. So you've got to look at your own environment. And we've done this at the Christie, and we think over on the right, an open EHR, open modular system, which is agile, and just one of the sentences that I love there, open semantically harmonized data model. Brilliant. So these are the things that we want to look at based on it's data-centric. Now, there are other situations in other hospitals, especially massive hospitals, where actually a single vendor EPR, so you buy an off-the-shelf product that can be massive, that they can be incredibly useful in those situations. But again, from our point of view, we've kind of matured through this for a number of years, and we want to focus on the data. So just to summarize some of the key benefits of this then. So we're changing our systems entirely underneath in order to get the data at the heart of this. And it's shifting to a data-centric approach rather than an application approach. And that second sentence there of data is more valuable than the application, I think that's just really powerful with that. It's not to say that every other part is not important. The user interface, the infrastructure, everything all plays a critical part of all of this. But you can have a lovely house and you can end up with a kitchen like we saw before if you don't focus on it. And that's just really important. So there's a couple of links there as well. We've got one of our suppliers is Better Care, and they adhere to OpenEHR. So everything that they do, whether it's meds, whether it's observations, whatever, it's all down to the same common data models. So I'm running with this analogy even more now, so just bear with us. So we want to figure out then what we can do in order to help our journey on AI and automation. And as part of this, we know the NHS is really stretched up and down the country. There's problems with obviously funding, the demand is huge. So we want to do whatever we can as a digital service to help all of our staff, and in turn, they help our patients and treat our patients. And I'll probably say that our clinicians or our admin staff, whoever, don't necessarily mind who or what helps them in a digital environment. So whether that's NLP, whether it's deep learning, whether it's machine learning, it could be robotic process automation, it could be integration, it could be that you configure the system a little bit better for them. It could be that you train them, and actually there's some digital skills that can really help people do their day jobs. So it could be all those things or all of those things. And just coming to this picture, you might have seen in the news a few weeks ago, there was a chap in Wales, and he had a messy shed. So messy shed, messy kitchen, so running with the analogy, and somebody or something tidied it up every evening. And it kept happening, didn't know why, so he put in a camera, and it turned out it was this little mouse that was tidying up his shed. And the reason why I'm saying that is that coming back to the messy kitchen analogy, you might say, well, if we had something just to tidy it all up, that'd be great. It could be, but you've got to be wary. And I think Fabio mentioned we need to ensure people trust it, people know what it's about. So it's not just a fortuitous example like a little Welsh mouse to clean things up. It actually needs evidence, and people need to be convinced about it. So even though the output of this chap had a clean shed in the morning, it's not something in theory that is scalable, so to speak, in that if you put that mouse in the other kitchen, actually make the problem worse, it'll probably just breed and create a huge problem in another way. So what I'm trying to say with all of that is that there are all these tools and techniques. You really just need to come back to understanding exactly what the problem is that you're applying it to, but it's just that translation into understanding and getting people along the journey with you. Otherwise, they might reject it, or it's not something that you can use in that particular circumstance. So just go out, I've left the analogies now, just for now. This is going into a little bit about how we are advised. So of course we reach out to various partners. Everybody's got their networks. You get information from wherever you can. Now, as a hospital, we are advised by a company called Gartner. They are international advisory experts across the IT domain, and they particularly help CIOs with tools, techniques, and really start to push the boundaries of thinking. So they try and get you thinking about things that are coming up, and then try and help you in your organizations to deal with them. And there's just a few quotes there from Gartner, and they're suggesting from an AI point of view, a few of these things that are just really just to get people, it might not translate to being true, but it's just thinking, well, it could be true, it might happen. So I'll just read out a couple. So by 2025, generative AI will be a workforce partner for 90% of companies globally. That's quite a lot, isn't it? By 2030, 80% of humans will engage with smart robots on a daily basis. AI in general will soon infuse everything we do. It'll transform our jobs and our organization. AI is not just a technology or a business trend, it's a profound shift in how humans and machines interact. And then the last one there, generative AI has made machines conversational, and they are quickly moving from being our tools to becoming our teammates. So how we interact is all completely changing. And we were lucky enough to go to the Gartner Expo. It was all about AI, and all of CIOs, CTOs were all thinking about this. And it's just fascinating. And you think this is going to obviously be a huge change. But from a healthcare perspective, how do we target that? How do we make it beneficial for us so it's not just a random event? So we thought we'd probably just need to go right back to basics and all this. So we've looked at AI, as I'm sure many of you have in the room for quite some time. And we've learned from that. We've seen the challenges, we've seen where it's gone wrong. So we're starting again, I suppose, in a certain way to look at all the stepping stones that we need in our AI journey. And part of this is because people now know with ChatGPT, all that kind of thing, it's something that people are talking about more. It's more accepted. People are looking at the future and trying to understand some of the things that might be possible now. So with our journey, we thought there's several steps that we probably need to take with this. So we need to start off really simple. Let's get a vision and principles together, get a strategy or a roadmap, whichever word you want to use for that, just for the first steps only. Being the NHS, we need policy. We need to figure out how that all interacts with our policy and our guidance. We need to prioritize as a very busy, every department, everything is so busy in the NHS, so you can't do everything. You need to prioritize. And that might be simply deciding what you shouldn't do, as well as what you should do. You need to then perhaps look at feasibility, risk, proof of concepts, and where you apply that to certain problems. So it all comes back to the improvements that you're trying to make, and that's got to be clear in your mind. So on that basis, you get a project with clear leaders, that problem's understood, really focused on your benefits, and hopefully that will help with all of that. And perhaps you might want a single point of contact group. So it's like a hub and spoke model. So in other words, the people that say, oh, I want to do this, can AI help? Or this is my problem. And then people get together and understand that certain solutions might help, one of which might be AI, one of which might be simply training or something like that, as we said before. So we could get a group together to help signpost people and advise them. So Gartner suggests when you peel it right back, there's 3 pillars to become AI ready. There's data protection and security on the left-hand side. Well, that's an entire other subject. We won't talk about that at the moment. That's huge in of itself. AI ready data, and that's where Open EHR comes in. So we're trying to tidy our kitchen and get everything sorted out from a data point of view. And we've got just a link there to Avenue 3. They're a company that's been instrumental in for us in the strategy around Open EHR. And then you've got AI ready principles. So thinking about all of the principles, you've got to think, well, where do we start? Where are we aiming? So in order to inform all of this, these are some of the little tools and techniques that Gartner help us with, just to get you thinking, just to separate out your thoughts. So this is called an AI opportunity radar. So over on the left-hand side, you've got everyday AI. So are we aiming at everyday AI? There's just a definition on the screen there. Over on the right, it's like game-changing AI. What is that? Anyway, game-changing. You know, this is a profound shift, perhaps. Are we aiming at that? Up at the top, you've got external customer-facing. So for us, that's our patients. Should we be putting AI right to our patients or not? So there's pros and cons to that, of course. Or it might be that you look right at the bottom and looking at internal operations. And the different sectors there show like back office, core capabilities, and so on. So in order to think about it, there's a few examples. So over on the left, it might be that we want to pursue productivity. So that sounds really attractive for the NHS, doesn't it? And you think, well, if we can get more productive at everything that we do, then that's surely going to help. It's not to exclude core capabilities or front of office. It's just that you might be focused on your back office, maybe to start with. In the middle, that's not in front of my customers. So again, it might be from a patient point of view. Let's not go there yet until we're real happy. Everybody's understanding what we're doing. We're all assured by it. Or you might go to the right and say, no, let's just go everywhere. Let's do everything and anything we possibly can. But at the bottom, there's just an output from Gartner's AI survey in that 77% of CIOs suggest that the productivity and efficiency gains are the most frequently cited benefit that they expect AI to create. And that's really attractive certainly from my point of view. So here's an example of that opportunity radar just filled in with some points. So for example, over in the bottom left in the back office, you can see EHR search and summarization. And for something like that, I think, yeah, well, that sounds pretty good. So Fabio's going into clinic. He sees it, he's got a new patient, he's bringing together all the records, looking in different systems. But if we could get that all summarized for him so that could help him be a lot quicker, then surely that could help. And yes, in theory it could, but that's in theory because there's some practicalities there as well. And we could do all of that. But when I was lucky enough to spend a little bit of time in clinic with Fabio and your team, and even if you get a referral letter in from another trust, from a medical colleague that says this is what's happening with the patient, you still go and double check. You still go right back to the pathology report because you want to ensure that's exactly the right information that you're given before you go in and see a patient, and they are trusting you with life-changing decisions. So you've got to be so sure about it. So it might be that you could do some search and summarization, but you also need to make sure that whoever you're providing to are absolutely confident with it. Otherwise, you'll just do the same thing you always have done and go back to the pathology report and just double check, which means that you've actually introduced clicks rather than remove them. So all good in theory, but it's just how do we implement? Lots of challenges. So I'm sure many of you will recognize some of these. Right at the top there, unable or hard to measure the value, lack of understanding of the benefits. And that is a real problem. But hopefully that is diminishing now as people get more used to what the capabilities could be. There's a whole bunch of data issues there as well in the middle, isn't there? So data quality, the volumes, all those kinds of things. And then it diminishes from there a little bit. But hopefully many of you can recognize some of these challenges. Just a note there on the right, a little bit more recent information. So this is a paper that came out in the last couple of weeks. So I think it was the 10th of January this year this came out. The application and use of artificial intelligence in cancer nursing, a systematic review. So it was actually one of the co-authors on that is our CCIO for nursing. So some of the Christie team have been involved in this paper. And one of the key messages that I got out of there was that implementation and use of artificial intelligence-based technologies is scarce. And that's a shame, isn't it? Because it's everywhere. We're talking to, we've got an entire institution here that can produce AI in loads of different ways, but the actual implementation and use of it is scarce. So that's a problem, isn't it? So coming back pairing it right back to our vision. So all the steps that we're saying that we should be taking as a trust. Called it our emerging vision because we haven't, this is all hot for press. We haven't got it all signed off as yet, but this is what we're going to be taking through to our digital board. It may change a little bit, but what we're trying to recognise with this is that we want to make a statement to say, actually, this is a journey that we all need to get on together. It's going to enhance our operations. That's what we want it to do. So that's maybe the areas that we're aiming for. We want to embrace this for efficiency and effectiveness, most likely. And we want to ensure the well-being of all we serve. And that's all we serve, as in it's not just patients, it's our staff. So this AI is probably mostly going to be aimed at our staff and staff benefits, which will in turn benefit our patients. So it could change, but this is what we're currently thinking at the moment. We talked about principles there and codes of practice. Now, over the last couple of years, I'm sure you'll know, loads of people have been doing work on all of this because there's been alarms going off about how AI can be biased, how ethical is it, all that kind of thing. So rather than reinvent it, we just had a look around at what exists now already. So this is 12 codes of practice standards from the UK government for digital and data-driven health and care technology. It can apply to other things as well as AI. Really, really useful. And I couldn't argue against it, so why not use it? So right at the top, you've got operating ethically. Clear value proposition. Is it usable? Are you technically assured? Is it clinically safe? And you need to delve into all of these things in order to build up that trust and assurance that we're talking about. There are other examples available. There's just a link there to the FDA as well. We also need to think about the context. So whilst we've got all of those 12 points of code of practice, actually there's different contexts of AI or technology in this way. So you can build it, you can buy it, you can co-develop it, you can evaluate it. And they've all got slightly different roles and responsibilities with that. So from an organization that's looking to implement this or go on the journey with it, we just need to figure out actually what are the differences here. So we've got some examples where we built it. We've got some examples where we bought it. We've got some examples right now that are going through evaluation. So there's, I think across Greater Manchester, I think there's a chest X-ray one, isn't there, that's putting some of the hopefully more acute cases right at the top so that clinicians can see them. Oh, great. But what do we do around roles and responsibilities? So we might know a little bit more about it. You might know a little bit more about it, but how can we get that across and understood in the organisation? Really busy NHS organisation. So over on the left-hand side, I know you can't see the detail, but I'll just explain a little bit about it because this, again, is just draft for example. So you've got all of those 12 points in code of practice in the first column going down. Across there, we've got the different contexts of build, evaluate, buy, and co-develop. And then it's trying to say who's responsible, accountable, consulted, and informed. So it's a big racing matrix around all of this. And we're trying to say, well, there are some situations where it might be a supplier that has a certain responsibility or accountability about part of this. It might be that it's the process owner, whoever that might be. So that might be I don't know, Fabio in clinic, or it could be the divisional management, or it could be perhaps ourselves that are consulted or informed from a technology point of view. So we just need to figure out who needs to be involved and where, and then we can support them that little bit more. So if you think about it, if our clinical divisions who are incredibly busy thinking about all kinds of stuff for operational running of services, if we're saying they're accountable for a certain part of AI, that'll probably scare them to start with because they don't know about it. So how can we take them on that journey, get them to understand it, get them to understand the role that they play? It's not every part of it, but there's certain parts of the role that they should play. And then how can we support them in doing that? And I think we've got to really go back and unpick all of this, because we are seeing these challenges as stopping AI being implemented. So we just need to figure out how to solve that. So that's probably where I'll leave it, in that we've probably done a couple of those stepping stones, not many. There's probably another 9 or 10 to go in order to get this really working for us as an NHS service. So I just want to say thank you very much, and hopefully that's quite thought-provoking, and we'll be open to questions.
Thank you both very much. Really enjoyed the talk. Before we go over to questions, one thing I thought was fascinating, and it shows how much the landscape has changed in the last couple of years. The first time we had you in, Fabio, was very much talking about diagnosis and medical imaging. And you can tell how much the landscape's changed, because ChatGPT has now just become ubiquitous everywhere. We're having to do the same thing at the university. I'm going to sort of ping in, well, if anybody's got any questions online, I'll ping between questions here and online. Does anybody have any questions for our panel in the room? Andy?
How different is your approach to what's happening in other parts of the NHS? So do you think you're ahead on this game, or do you think there's a lot of others on the same journey?
Yes, it's an interesting one, because it's often difficult to tell where a lot of the other organisations are unless they go and speak about it, or you can find out in different ways. So we do have connections, counterparts that we can talk to. I think what we can see, and this is a limited view, so this can't be hundreds of trusts around the country. What we do see is people developing and going down routes where we can recognise it. So we've done some of this before, and you can see where different organisations are starting that journey. Equally, I've seen other organisations where they're saying, I tell you what, we're not going to even think about developing. All we're going to do is just buy. So when a big corporate organisation produces, I don't know, something that's imaging or pathology AI, and it's validated, it's got all the assurances, we'll just buy that rather than develop our own, because that could be applicable to our circumstance. So in other words, they're thinking about not what they should do, but what they're not doing. So you'll get all this spectrum in between. And I think from our perspective, this is why I think we just need to go through the process of trying to understand where we need to be. So to a certain extent, it sort of doesn't matter where everybody else is, and we need to figure out what we want to do, because we've got this great situation, haven't we, with cancer patients in and around Manchester. We've got organisations like yourself on our doorstep. So maybe we're different to a small NHS trust in Kent. I don't know. So we just need to figure out what we should be doing, and that's part of this journey, really.
And I would just add that I think the fact that we have absolute control over our electronic health record, it's, we have the control over it. It comes with more responsibility as well, because there's a lot more work that comes with it, but it means that we can adapt, whilst other trusts might need to put a request in queue because that same company is providing for many others, and that may not be a priority at the time, might take a while. We have that control. That doesn't mean we can do everything overnight, but that means we can control.
Alan?
So it's clinical outcomes data unit. Is it, well integrated with the tissue banks within the Christie?
So to a degree, and we doing it.
Yeah, I'll get this. It's a good point. So yes, we've got a bit of a plan to do more there. So we're talking about the biobank particularly. So we work closely with the biobank. We interchange data to just try and help them practically. So I think previously they've had a team of people going around to try and find the treatment data associated with the tissue samples that we've got. We can help them with that, and we are doing more of that now. We just created just a more of a data exchange and produced a dashboard on the back of it to try and help clinicians, particularly, just understand where our samples are, what kind of disease groups, where we're light on samples, that kind of thing. So that's all in the mix at the moment. We know we can go further, and we've been talking to some other trusts in the country about what they're doing there as well. But yes, there is a project around that to help develop that more. I think there's opportunities in the GM environment to do a little bit there as well in the secure data environment. So that's a consideration too.
I guess where the vision is that it will get to a point where it's similar to our bloods. So I can go onto our records and see, yes, these are the bloods for this patient, but I want to see as well how many samples do we have, what tissue is, when will we have.
Yeah.
So we're getting there. So the dashboard is the first step to link the clinical data with the samples. But we want that to become much more integrated within the electronic health record. So it's much easier to understand. And it makes it easier to ask a question because you might have an idea, but then I don't know if I have samples.
Exactly. So for me, starting point would be that dashboard. We start from there and then move on to the request. Thanks.
1 second, Matt. Aaron, do we have any questions online?
At the moment,
Just
no.
in the chat. Matt, you got a question?
You sort of primed my question, Matt, by mentioning the secure data environments. My question is about how this data can be integrated with wider data across GM, and is there a plan to have some connection with the secure data environments?
Yes, absolutely. So we see a lot of advantages with the GM secure data environment. Of course, that's the project is across the Northwest as well, isn't it there? So we want to play our part in sharing, hopefully, the right and relevant data at whatever quality, hopefully a good quality within that environment, because that can lead to more opportunities that we can't just do ourselves. So we recognise some of the benefits of that. We've been doing what we can to ensure that we are part of it. We've been on the delivery groups and so on, just to help with that. So we absolutely recognise that as an opportunity.
Question at the back.
Just in terms of setting up the digital unit and implementing AI, I was just interested to see whether you sort of worked with or clinical scientist workforce. They are quite often the experts in this area, so I'm just interested to see if
But I think we are quite early days in that process. So what we've done so far is we've drafted what could be a framework of trying to implement it. And that came actually on the back of that example of the AI for acute kidney injury. But what we haven't done a lot yet is socializing that across the different teams, the different clinical teams as well, because that's where there is actually that was a starting point, because that's where we saw the resistance, and you could see the clear divide, people saying yes and others saying I don't know. So that led us to think we need that. So our plan is to bring that, and we've already did that with I think at least one consultant group. I think it was medical oncologists that we brought that to them, but we need to socialize that more. And our plan is that we approve that as a framework, and obviously things evolve and change. We're pretty sure that's not going to be set in stone, but for that to be our first step, and I completely agree, I think those groups are key. But what we want is to find a way, perhaps, to give people, I think it's more about giving people confidence. And we want people to know, well, I have this idea, I would like to do something, what are the steps? So that I think that's why we feel that it's needed. So it's not, it's not super detailed, but it is to provide some guidance.
One more quick question. Anthony.
Yeah, it's really fascinating hearing the two of you talk about this, and thank you so much for a really interesting talk. I wanted to ask about one of the things that we struggle with at MFT, I think, is getting our clinicians to realise the value of the work that you're doing, because they just expect that you can just be given data, and that's fine. So what's the? Have you got? How are you having that dialogue? I'd be really interested to hear what that's like.
I think we both have a lot of comments on that. So you always find, that's been our experience, and I'm pretty sure that's across every trust, there will always be the ones that are the early adopters, the ones that are there, that are keen and they are reasonable and they understand. And then there is the group that is less reasonable, perhaps a little bit more resistant to some changes or proposals. So all that I'm saying is, I think what we've done has been an approach that we have prioritized the ones that are more engaged. And we've seen that, for example, I think an example we've used was when we as a trust launched our patient reported outcomes. So it's an online platform that patients get text messages or emails when they're coming to our clinic so they can report on quality of life and symptoms. Quickly realized that no, there was a lot of resistance, there wasn't a lot of engagement, but some teams did. And suddenly once team A and team B had it, team C wanted as well. And then suddenly team C is on board, and then you go to team D. And then if the other ones are doing this way, maybe we'll do it as well. So that helped. It takes time, but it helped that others came more on board. And I feel that we are going to follow in a way a similar approach. It doesn't mean that we're obviously going to ignore the teams that aren't as engaged, because probably we definitely need to engage with them, but hopefully we will soften things a little bit by working with the ones that are already more engaged, that work more closely with us. And it's not necessarily the whole team. Sometimes there are groups within that team that are really on board and really engaged. So I think that has been informally our approach and has worked. Even now, when we're talking about the redevelopment of our electronic health record and changing how some forms would look, we've said we're going to pilot it with some teams and then grow to the others, because we knew if we would go at front with everyone, we would never get anywhere.
Yeah, just going to add, there's always going to be challenges like that, isn't there? And you just got to keep at it. And I think one thing that I've learned throughout this journey, because we started the original outcomes like 10 years ago, and I think you just got to keep going, keep trying, try something different, try it again. And as we were just explaining with this journey here, is that opportunity of ChatGPT amongst the world's population, understanding what this is about and thinking differently. It's like, right, how can you use that just to re-engage with people that might not have engaged previously? And that's why we're saying it can help then, just almost like just going back to the start and just building up again, and hopefully bringing more people on with you than you would have done previously. And that might get to a certain point, and we might have to reboot again at some point. Who knows? But you just got to keep going, I think.
I think it might have helped us a little bit as well. The fact it's a big research center, so I think that already means that there is perhaps a bit biased, because it is a trust that has perhaps a bigger proportion than other trusts that are more data savvy, data aware, etc. So that might make our lives a little bit easier, but there will always be resistance.
Last time, gentlemen, that was a really great talk. Thank you very much, and thank you for coming down today.